Peace, peace, peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. So peace. Welcome, everyone. What's going on, y'all? Chapter 31. Page 460. The post-surgical patient. Page 460. The pulmonary insult of surgical intervention. Surgical intervention is frequently followed by pulmonary disease. This is partly due to the body's increased metabolic responses to trauma, surgical insult, leaving uninvolved and previously normal organ systems, e.g., urinary tract and lungs, vulnerable to infection. However, it is also due to the fact that postoperative abdominal and thoracic surgical patients experience unique predictable pulmonary function alterations. These transient physiologic alterations must be appreciated by the respiratory care practitioner and the physician involved in postoperative care. Reduction of vital capacity. The observation that vital capacity is reduced 50 to 75% within 24 hours following thoracic or abdominal surgery was first reported in 1927. This observation has been reconfirmed numerous times and has proved to be extremely consistent. Normal adult vital capacity is reported to range between 55 and 85 milliliters over kg of normal body weight. Thus, an insult causing an acute decrease of up to 75% in vital capacity would leave most normal individuals with a vital capacity greater than 15 milliliters kg. As discussed in Chapter 3 and Section 3, any acute decrease in vital capacity that remains in excess of 15 milliliters over kg should transiently provide an adequate ventilatory reserve and allow adequate deep breathing and coughing. The postoperative vital capacity reduction occurs gradually over 12 to 18 hours following the surgical procedure. Therefore, the patient's ventilatory reserve, see Chapter 3, will usually be significantly less than 12 hours postoperatively than immediately following the surgical procedure. A clinical axiom of respiratory evaluation in post-surgical patients states the vital capacity is maximally reduced 12 to 18 hours postoperatively and then gradually improves unless complications intervene. Ding! Mm, mm, mm. I'm gonna read that again because it's very key. I know. I will put the vocabulary in the description. we're getting down, we're at the end of this book, ladies and gentlemen. So thank you so much. You're getting to see it live. I will be putting it all in the replays, and you'll just tap on it just like the other books on this channel, and you'll just be able to read along with it. So thank you for being here. I really appreciate that. Like, highest heart love, for real. In the now moment. Love to all our friends and family. I'm going to read it again. The vital capacity is maximally reduced 12 to 18 hours post-operatively and then gradually improves unless complications intervene. Most patients with an uncomplicated course approach their preoperative vital capacities by the third or fourth postoperative day. Clinical guidelines. The reproducibility of surgically induced vital capacity reduction has allowed the following clinical guidelines to be developed, and they have proved reliable beyond any reasonable doubt. 1. Elective upper abdominal procedures or thoracic procedures involving splitting of the sternum wall will, within 24 hours, result in a 60 to 75% decrease in the preoperative vital capacity. 2. Elective lower abdominal or thoracic procedures will, within 24 hours, result in 30 to 50% decrease in the postoperative or preoperative vital capacity. And 3. Elective non-thorax thoracoabdominal procedures will usually result in little postoperative vital capacity reduction. However, reductions resulting from anesthesia and narcotics are variable. Routine monitoring. The simplest means of clinically monitoring the postoperative severity of vital capacity reduction is to serially observe the respiratory rate. Acute decreases in vital capacity usually result in rapid and shallow ventilatory patterns. See Chapter 3. When an adult postoperative patient's respiratory rate becomes progressively faster in the first 12 hours and approaches 30 per minute, it usually reflects significant loss of ventilatory reserve unless significant pain is present. In such circumstances, it is advisable to serially measure vital capacity, tidal volume, and arterial blood gases in addition to performing frequent clinical chest examinations. The acute restrictive pattern, figure 31 1. The predictable postoperative restriction in total lung capacity is believed secondary to the limitation of diaphragm and chest wall muscular activity. In other words, the thoracic the thorax is limiting the inflation capability of reasonable, unaltered lungs. One may anticipate that this would result in minimal diminishment of residual volume, since airway closure would tend to maintain residual volume in the basilar areas. Thus, the significant reduction in total lung capacity would be primarily at the expense of the vital capacity. Figure 31 1 represents this type of acute restrictive disease. It might also be anticipated that hypoxemia resulting from this kind of restrictive pulmonary disease would be the result of shunt effect. See chapters 4, 6, and 7, and thereby be responsive to oxygen therapy. Summary. Abdominal and thoracic surgical intervention results in transit acute restrictive pulmonary abnormality that primarily affects vital capacity. The resulting limitation in ventilatory reserves is reasonably predictable, and the resulting hypoxemia is readily responsive to moderate levels, 30 to 40% of oxygen therapy. Top of page 462. Pulmonary complications of surgical intervention. Most patients survive the acute restrictive pulmonary insult of elective thoracic and abdominal surgery with few detectable clinical problems. However, cardiopulmonary homeostasis is significantly stressed in many patients and results in complications. These postoperative pulmonary complications may be separated into two general categories: acute ventilatory failure and atelectasis pneumonia. Although the complications are often difficult to clinically differentiate, it is convenient to separate them for purpose of discussion. For simplicity and clarity, variables such as cardiovascular, hepatorenal, and CNS function, as well as surgical technique and general medical care, are not emphasized in the following discussions. However, these variables must always be considered in actual clinical evaluation. And here we go. Figure 31.1. All right. There you go. It's A, represents the normal relationships between lung volumes compliance and VA over Q. B, represents the changes that occur in the uncomplicated post abdominal or thoracic surgery patient. See text. IRV equals inspiratory reserve volume. VT equals tidal volume. ERV equals expiratory reserve volume. And RV equals residual volume. So here you go. A in the top, as you see, the pressure is evened out on the curve, right, of the lung. And B, you'll see that it slices through. Okay. In the title volume. Thank you so much. Peace, peace. Highest heart love, everyone. Much love. Yes, we're back at it. It gave time. I had a lot of work. Been working all day. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're in the 31st chapter. Woo, in the 460s. This is 462. All right. And moving to 463. Peace, everyone. Highest heart love. Oh, thank you so much for reading with us. Peace, peace. Highest heart love. Yeah. Thank you for the likes, loves, and hearts. Oh, I see you. We're reading live from the light here in LA. Love to all of you. Gratitude and highest heart love. All right, top of page 463. We just started the 31st chapter. Here we go. Post-surgical patient and acute ventilatory failure. Acute ventilatory failure is defined as the sudden inability of pulmonary system to adequately meet the metabolic demands of the body in reference to carbon dioxide homeostasis. See chapter 4. Through blood gas measurements, this condition is clinically detectable by an arterial PCO2 greater than 50 millimeters Hg in conjunction with a pH below 7.30. This may occur secondary to the significant increase in the energy required for adequate physiologic ventilation in the first 24 post-operative hours, as illustrated in figure 31.1, which we just looked at. The 1, ventilatory reserve vital capacity is significantly decreased from normal. 2, lung compliance is less than normal. And 3, ventilation perfusion relationships are less than optimal. When vital capacity becomes less than 10 milliliters over kg for a significant period, the capabilities to provide the energy required for adequate ventilation are greatly decreased. See Chapter 19. In addition, any increase in airway resistance will increase the work of breathing, whereas any cardiovascular, hepatorenal, or CNS abnormality will decrease the patient's ability to meet increased energy requirements for ventilation. Peace, eyes, heart, love. Thank you so much. Awesome. Peace, Roman. Eyes, heart, love. Yes. Thank you. Thank you. Thank you. Thank you. Gratitude. Sending this love and channeling it also to the great Lorianne Speed, who we love dearly. Breathing in through the nose. Always, that's right. The Most High is with us. That's right. Channel all this energy, the peace. That's what we're here for in this quiet peace part of YouTube. You know, send love and healing energy of the abundance that we have. That's why we're reading this book. Clinical application of respiratory care. All right. Here we go. 31st chapter we're in. Clinical guideline. A general guideline and reference point for estimating the probability of ventilatory failure in the first 24 hours is as follows. For an upper abdominal procedure in a patient with a normal cardiovascular, hepatorenal, and central nervous system, or CNS, if percentage FVC plus percentage of FEV or over FVC is less than 100, there is a 50% chance of that patient experiencing acute ventilatory failure in the first 24 hours. This rule of thumb reflects the fact that if the patient is normal in all systems except pulmonary and that pulmonary disease significantly limits ventilatory reserve, the chances of ventilatory failure caused by the surgical insult are great. That's why we always coaching breathing in through the nose and releasing. I would always in my classes and was teaching my daughter early on blowing a pinwheel, and you see the sparkly pinwheels and start here and blow the pinwheel. Collect it down here. Blow the pinwheel. Then extend it out further. Blow the pinwheel. This is a check on our energy, on our reserves, right? All right. This. If the patient is normal in all systems except pulmonary, and the fact that if the patient is normal in all of the systems except pulmonary and the pulmonary disease significantly limits ventilatory reserve, the chances of ventilatory failure caused by the surgical insult are great. Of course, significant disease in any other organ system will increase the chances of ventilatory failure. This becomes an extremely important guideline for major decisions such as 1. Maintaining the patient in an intensive care area for the first 24 hours for monitoring purposes. 2. Applying early, aggressive bronchial hygiene therapy. And 3. Providing elective ventilatory support for the first 24 hours postoperatively. Bottom of page 463. Atelectasis and pneumonia. A decreased FRC, decreased vital capacity, and the absence of periodic deep inflations are believed the main factors contributing to retained secretions and stasis pneumonia. Section 3. It stands to reason that any intrinsic lung abnormality would tend to exaggerate the process. This is why I always tell ISIS, say, spit it out. We want to get the secretions out of our body. Spit it out. We'll exaggerate the process. The incidence of atelectasis and pneumonia after abdominal and thoracic surgery has been reported to be 12 to 80%. The disparity is probably explainable by such variables as 1. The surgical procedure undertaken. 2. Surgical technique. 3. Preoperative condition of the patient. 4. Pre and postoperative care. 5. Retrospective versus prospective investigation. And 6. Criteria used for diagnosing atelectasis and pneumonia. Perhaps the most practical way to utilize the available information is to compare the incidence within each study with the various factors believed to influence the incidence of pulmonary complications. Table 31.1 is the compilation of such a comparison and emphasizes that the single most useful clinical factor for delineating the postoperative patient at high risk for atelectasis and pneumonia is the abnormal expiratory spirogram. This effective, non invasive bedside measurement has always proved simple and inexpensive. All right, here we go. So this is table 31.1. Incidence of postoperative pulmonary complications in relation to various factors. Abnormal pulmonary function study. Normal, 23 over 1. Abdominal operation over non-abdominal, 4 to 1. Smoking history over non-smoker, 4 to 1. Above 60 years over under 60 years, 3 to 1. Overweight, 20% to over not overweight, 2 to 1. Top of page 464. Common pulmonary pathology, the post-surgical patient. Here we go. Thank you so much for reading books with us. Hi, it's Heart Love. Happy Tuesday. We're going into Wednesdays, the 11/11 portal. We just soaked it all in. We used it all up. Now, just sit in the peace at the still point and receive. Receive this love. Receive the reading. Peace. This is when the healing comes. Classifying the risk for postoperative pulmonary complications. The anticipated abdominal or thoracic surgical procedure must be clearly identified. Past medical history of pre existent lung disease, smoking, sputum production, exercise tolerance, and restrictive and obstructive pneumonia and phenomena must be examined. Information as to pre-existing cardiovascular disease, dyspnea, or exertion, orthopnea, pa- paroxysmal nocturnal dyspnea, dependent edema, and evidence of congestive heart failure, angina, and myocardial infarctions must be noted. Any pre existent renal disease and metabolic disease must be evaluated. Physical examination as to body weight, state of nutrition, color, and temperature of the skin, chest configuration, skeletal abnormalities, pattern of ventilation, and auscultatory findings of the chest, including heart tones and murmurs, are essential. General laboratory studies, including ECG and chest x ray, must be evaluated. At minimum, a forced expiratory spirogram must be obtained, and if advisable, complete pulmonary function studies accomplished. If indicated, a blood gas measurement to further evaluate the pulmonary gas exchange should be made. A reliable system for generally arriving at a risk category for pulmonary complications in the patient undergoing abdominal or thoracic surgery is put forth in Table 31. 2. Each of the five categories is evaluated and the patient ascribed a total score from 0 to 7. Only one score is assigned for each variable, making 7 the highest score possible. Here we go. Top of page 465, table 31, 2. Classification of risk of pulmonary complications of thoracic and abdominal procedures. And as the points all the way here in this vertical bar, and category over here. 1. Expiratory spirogram. A. Normal. Percentage FVC plus percentage FEV over FVC is greater than 150. B. Percentage of FVC plus percentage FEV over FVC equals 100 minus 150. C. Percentage of FVC plus percentage of FEV over FVC is less than 100. D. Preoperative FVC less than 20 milliliters kg. E. Postbronchial dilator FEV over FVC is less than 50%. All right. And the points for those are 0, 1, 2, 3, and 3. 2 is cardiovascular system. A. Normal. Points 0. B. Controlled hypertension. Myocardial infarction without sequelae for more than 2 years. 0. C. Dyspnea on exertion. Orthopnea. Paroxysmal nocturnal dyspnea. Dependent edema. Congestive heart failure. Angina. 1 is the point. And then 3. Nervous system. A. Normal. B. Confusion, obtundation, agitation, spasticity, discoordination, bulbar malfunction. 1. C. Significant muscular weakness. 1. 4. Arterial blood gases. A. Acceptable. 0 points. B. PaCO2 greater than 50 millimeters Hg or PaO2 less than 60 millimeters Hg on room air. 1 point. C. Metabolic pH abnormality greater than 7.50 or less than 7.30. 1 point. And 5. Postoperative ambulation. A. Expected ambulation minimum sitting at bedside within 36 hours is 0. Mm. B. Expected complete bed confinement for at least 36 hours. 1 point. 0 points equal low risk. 1 to 2 points equal moderate risk. And less than 3 points or 3 points less equals high risk. There we go. This is table 31-2. Classifications of risk of pulmonary complications of thoracic and abdominal procedures. Here we go. In clinical application of respiratory care. This is how we do it. Giving the people the information for free, thousands of dollars worth of information to the people for free here on YouTube where it's peaceful. Thank you so much. Highest heart, love, and honor. Low risk, 0 points. When the patient receives no points, there should be little expectation that he or she will have pulmonary complications postoperatively. Incentive spirometry may prove useful, but above all, the patient must be encouraged to cough and deep breathe frequently. Oxygen therapy is usually not necessarily after discharge from the recovery room. Moderate risk, 1 or 2 points. These patients have a significant incidence of postoperative complications, i.e., atelectasis, pneumonia, decreased basilar breath sounds, fever of unknown origin, or mild hypoxemia. However, if properly treated, these entities should not prove life-threatening. These patients deserve a careful evaluation for postoperative bronchial hygiene. See Chapter 14, and their pulmonary status should be followed carefully by the physician. Incentive spirometry is definitely indicated as a prophylactic measure, and therapeutic measures, see Section 3, should be instituted when indicated. Serious consideration should be given to daily vital capacity measurements and arterial blood gas measurements to aid the physician in his or her pulmonary evaluation. Oxygen therapy is often indicated for several postoperative days. High risk, 3 or more points. Middle of page 466. These patients should be seriously considered for remaining in an intensive care area for 24 to 48 hours postoperatively. Serial evaluation of cardiopulmonary reserves is indicated, as well as evaluation for aggressive bronchial hygiene therapy. A preoperative FVC of less than 20 milliliters over kg places the patient at high risk for acute ventilatory failure in the postoperative period. These patients deserve careful evaluation and may be candidates for elective ventilatory support, ventilator support. Significant preoperative irreversible airway obstruction will significantly increase the postoperative work of breathing and diminish bronchial hygiene capability. In our experience, a patient free of pulmonary infection who manifests a post-bronchodilator percentage FEV over FVC of less than 50% should be considered at high risk for postoperative pulmonary complication. Peace, highest heart love. Thank you so much. Oh, so much love. Read and look at the likes and subs. We're pushing towards 600 on this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. Thank you so much for being here. Highest heart love. Oh my goodness. So much love. So much love. Peace. We're doing it. Yeah. The 1111 portal. Just bringing it in. Channeling it. Love, love. Thank It must be stated emphatically that the authors are not presuming that this system can predict a patient's capability to withstand an abdominal or thoracic surgical procedure. Rather, we are stating that the system aids in identifying the patient at moderate and high risk for pulmonary complications. The analysis is dependent upon an adequate preoperative respiratory care evaluation and a thorough understanding of the factors contributing to the incidence of postoperative pulmonary complication. High risk postoperative respiratory care. It's all about the care. See, I'm going to do this now. Care. C. A. R. E. E. It's the E. The A. Care. That's what it takes. Heart. That's why we say that. Come on. Have a heart. A resonance. Breathe that in. What does care mean to you? Compassion. Top of page 467. Patients classified as a high risk should be placed in an appropriate intensive care area for at least the first 24 hours. The more limited the patient's reserves, the greater the need for serial blood gas measurements, since they alone provide a reflection of the adequacy of physiologic gas exchange in the pulmonary system. Serial blood gas measurements assure the appropriateness of oxygen therapy, assure that appropriate ventilation is being provided, and provide a reflection of acid base status. It is our recommendation that indwelling arterial lines be established postoperatively, if not already accomplished before or during the operative procedure. This will ensure the availability of serial blood gas samples, even in the event of hemodynamic instability. Frequent measurement of mechanical pulmonary function parameters such as vital capacity, tidal volume, and rate of ventilation is essential. The ventilatory pattern must be serially assessed and compared with blood gas measurements. This will allow a reasonable assessment of the physiologic efficiency of ventilation and will aid in clinical assessment of the work of breathing. See chapters 3 and 19. Maintenance of an adequate airway is essential. The decision whether or not to keep an endotracheal tube in place is critical. It is generally advisable in high risk patients to establish a nasotracheal tube during the operative procedure and leave it in place until the patient meets criteria for extubation. However, in some patients, it is important to extubate early, such as the asthmatic, to avoid bronchospasms and the severe COPD patient to allow glottic mechanism to function normally. If the COPD patient must remain intubated, 5 centimeters H2O PEEP is suggested. See chapter 24. Postoperative ventilator support may be indicated in the patient who shows an inability to maintain an adequate ventilatory state, or it may be initiated on an elective basis in response to increased chances of ventilatory failure. Mechanical support of ventilation in postoperative patient follows the same general principles outlined for all ventilator care. See chapters 22 and 23. Through though most patients tolerate a control mode satisfactorily, the use of augmented modes of ventilation should be encouraged whenever possible. Pain relief is essential in the early postoperative period and will greatly affect coughing and deep breathing. Ding! All right. Sedated, they're going to breathe different than without it, especially whether in pain. That's why we can always tell someone in the words, in their actions, if their sympathetic nervous system has been compromised, right? It's a part of the recognition, the awareness level that we have to be as the healers, as the healthcare providers, right? It's to know, oh, they're in pain. Sometimes people get hit with something so hard they can't even speak and express the level of pain. That's when we're speaking of this, right? All right. Timeless. The patient who has adequate pain relief will actually breathe more deeply and cough better than the patient who is experiencing significant pain. Thus, pain relief is not only humane, it is physiologically desirable. In the critical care area, narcotics should be administered in small, frequent doses by the intravenous route. Such techniques as lumbar and thoracic epidural catheters may prove desirable for pain relief in certain high risk patients. Preoperative bronchial hygiene therapy. Patients with significant retained secretions should have an aggressive preoperative bronchial hygiene program instituted. This often results in significant increases in vital capacity and or forced expiratory volumes. It is our experience that a preoperative bronchial hygiene program can usually accomplish its goals within 48 hours. Any preoperative program must include proper preparations for the postoperative bronchial hygiene program. At minimum, this should include instructing the patient in breathing exercises, cough methods, and other techniques of enhancing his or her postoperative ventilatory muscle mechanics. This is the opportune time to familiarize the patient with the expected postoperative course and the techniques, equipment, and procedures planned for postoperative bronchial hygiene therapy. Preoperative instruction and physiologic reassurance remove a great deal of anxiety and pain from the postoperative period. We have found that these patients appear to have better results from their postoperative bronchial hygiene program because of the preoperative instruction. With well ordered communication between surgeons, nursing staff, and a smoothly running respiratory therapy department, the indicated preoperative program can be accomplished without causing delay in the surgical schedule. Teamwork makes the dream work. Here we go. Last paragraphs. We did it. Completed chapter 31. Wondering. It's only right that I do that, right? Routine postoperative bronchial hygiene. Postoperative bronchial hygiene therapy has become the vogue in the past years and is presently the subject of much controversy. If perfect postoperative nursing care existed, there would be no need for routine respiratory therapy. It is impossible to justify the expense and personal time involved in routine postoperative respiratory therapy for low risk patients. However, neither nursing staffs nor physicians have the time or training to effectively apply appropriate stirrup regimens to high risk patients. The answer, obviously, lies in the ability to preoperatively distinguish the high risk from the moderate risk patient and preoperatively apply respiratory therapy in the postoperative period. Remember, therapeutically indicated bronchial hygiene therapy in critically ill patients is dramatic in its results. However, the efficacy of the prophylactic bronchial hygiene therapy has never been documented. Wow, back then it hadn't been documented. This is 1979. See, that's what I love. Oh my goodness. It's so beautiful. Look at that. Now we know. Oh, hi, it's hard. The only possible justification for expensive and time consuming prophylactic bronchial hygiene therapy is in the high risk postoperative patient. And even in that circumstance, it remains controversial. The rationale for application of incentive spirometry, IPPB, aerosol, and chest physical therapy has been discussed in detail in Section 3. Most surgical patients are healthy and undergo non abdominal procedures, making them low risk patients needing no more than minimal stir up regimens, e.g., incentive spirometry, good nursing care, early ambulation. The need and effectiveness of bronchial hygiene therapy in the great majority of surgical patients are readily judged by common sense and a few well understood guidelines. The need and effectiveness of bronchial hygiene therapy in high risk patients and those undergoing extensive major surgery must be judged on logical and unbiased grounds. The answer is far from clear. Woo! Completion, completion of chapter 31. We did it in one read. Highest heart love. Had to get on here and bring you to peace. You know, it's been a couple days. Also been working a lot. Started off this early rising, went on my early AM run, did my push-ups and recycled a lot. And was in Hollywood. The whole time I'm praying for all of us. The whole time. Loving on us. Straight up. I love you so much. We did it. Thank you so much. Thank you so much. It's heart love. We completed chapter 31 in one read. So when we reconvene, we are going into chapter 32 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Wow. Wonderful, wonderful, wonderful. Oh, much love. Look at that. We did it. One read, right? That's how we got to do. Let's have a glass of love water, right? Hold on. Here we go. Gotta grab it. You know, always want the best for us, man. That's what this is all about. Reading to everyone. We're the champions of reading, you know, on YouTube, that's for sure. Guys, I have such an abundance right now of love, care, of this beautiful gift. Wow. I'm looking at like where I'm going to set it up. See, it's all about honor with me. Like, that's what it's always been about. We honor our friends and family. We honor ourselves. You know, that's how it works. Just like honoring nature. When we honor nature, we're honoring ourselves. Love to all the veterans. We love you, my dad, grandpops, both sides, uncles, brother. Love you. Thank you so much for representing. You carry so much on your back. Dad, I love you so much. Kevin, Jonathan, Riley. Man, yeah. I love you so much, man. We be shaking it up on YouTube. That's for real. They be like, what is he reading? High levels. That's what we do. Live from the light. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Shaking it up. Shake it up. Love to the Lorian Speed. Love you so much. All the beautiful, beautiful birthdays. And Cliff, cousin Cliff, he's a man. Always been such honor and love and respect. We made it to November 2025. Awesome. Yes, 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 that's what it is. Respiratory care. So, love and healing energy to the great love. Glory and speed, sending you this love. The healing wish that you rest well. We will meditate with this piece, completed another chapter, inspired. I love you. Glass of love water for you. Love you. Mm, mm, I love you. I love you. I love you. Thank you so much. Love you. Thank you for being here, reading books with us, being in community, all friends and family, right? This is for all the veterans, all the nurses, and breast techs, and M-techs, and healers of this world, singers, artists. We love you. I love you. I love you. Because I love myself. Thank you for being here. All right, so I will see you soon. Going into chapter 32. All the poets. All right, so love. We love you, Lorian. Peace. We'll see you soon.